Let's get to work, and thank you all very much for being here. And we want to thank C-SPAN for covering this important hearing. And I especially want to thank our witnesses, some of whom have traveled from very long distances from around the world to be with us today. We very much appreciate your being here. The United States has, I think, a very effective form of government in the sense that we are a federalist system, which means that we have 50 separate states, and it is very common that one state learns from what another state is doing. So every day in California or North Carolina or Vermont, somebody is coming up with an idea or a program. It works. Other people steal those ideas, learn from those ideas, and that's, I think, a pretty effective way of going forward. I do not believe that we utilize that practice as much as we should internationally. The United States is not the only country on earth. There are other countries that are doing very positive, interesting things, and we should be learning from them. And in a sense, that's what this hearing is about, is to see what we can learn from other countries around the world in terms of health care. And in my view, in fact, we have a whole lot to learn. Because at the end of the day, the United States spends far more per capita on health care. We spend almost twice as much per person on health care, and yet we have many millions of people who are uninsured, and our health care outcomes, compared to many other countries, are not particularly good. And that's my starting premise. Why is that? And what can we learn from other countries who in many ways are doing better than we can? So let me start off with just a couple of basic facts about the American healthcare system. While it is absolutely true that some Americans, often those with a lot of money, receive some of the best cutting-edge healthcare in the world, it is also true that for millions of low and moderate income Americans, they have little or no access to even the most basic health care services. And later on, I think maybe as part of the questions or answers, we're going to show a photograph that many of you have seen of in Virginia or California, people lining up in fields to get basic health care or to get their teeth, rotted teeth, extracted, photographs that would remind you of a third world country. The reality is that today, the United States is the only major country on earth that does not guarantee health care as a right. And that is a basic philosophical debate that we have to have. Should all Americans, regardless of their income, have access to health care as a right or not? The United States is the only nation in the industrialized world that says, no, you're not entitled to health care as a right. In 2012, more than 15% of our population, nearly 48 million Americans, were uninsured. But that's only half the story, because many people who had insurance also had high deductibles and high co-payments. And those payments created situations where people hesitated to go to the doctor when they should. Not to mention other people leaving hospital deeply in debt and going bankrupt. Is that something that we are proud of? Here's another important point to be made. We talk about rationing and so forth. Of course, in the United States, healthcare is rationed, but it is rationed by ability to pay, by income. According to a Harvard study published in Health Affairs 2009 and Health Affairs in 2014, some 45,000 Americans die every year because of a lack of access to health care. And I have talked to doctors. I don't know if my colleagues in their states have talked to doctors. I have talked to doctors who say, yeah, people walk in the door and they are now terminally ill. And the doctor said, why didn't you come in here 6 months ago? Why didn't you come in here a year ago? And people say, well, I didn't have any health insurance. I didn't want any charity. I thought I would get better. So we're losing some 45,000 people a year because they don't get to a doctor when they should. There are, furthermore, communities around this country. I know Senator Roberts of Kansas mentioned this in a hearing we had a while back, where there are no doctors. There are towns in Kansas, no doctors in the area at all. People do not have access to basic primary care. Now, despite all of that, the United States, as I mentioned a moment ago, spends almost twice as much per capita on health care as does any other country. We are spending about 18% of our gross domestic product on health care, compared to 11 to 12% in France, Germany, Denmark, and Canada, 9% in the UK, Australia, and Norway, and less than 8% in Taiwan and Israel. And we're going to hear a representative from Taiwan in a few minutes. In terms of efficiency, are we an efficient system? Compared to the huge amount of money that we're spending, are we getting good value? In August 2013, Bloomberg, a respected business source, ranked the United States healthcare system 46th of 48 countries based on efficiency. Now, what about outcomes? You know, if I'm spending $100,000 on a car and somebody's spending $20,000 on a car, we would assume that my car runs better. I'm getting better value. I'm getting value for what I pay for. Well, the United States pays almost twice as much per person for health care, but in terms of our health care outcomes, we do not do particularly well compared to other countries around the world. Among OECD countries, the United States ranks 26th in terms of life expectancy. Residents of Italy, Spain, France, Australia, Israel, Norway, and the list goes on, will live 2 to 3 years longer than Americans. So in terms of our outcomes, they're not particularly good. What about prescription drugs? Clearly, when we go to the doctors, very often the therapy is medicine. I recall talking to a doctor in northern Vermont who told me that about 25% of the patients that she sees, and when she writes prescriptions for, are unable to fill those prescriptions because they're just too expensive. The fact of the matter is the pharmaceutical industry in this country earns huge profits and charges our people the highest prices in the world for prescription drugs. There's a lot more to be said, but let me end my remarks with those comments, and I look forward to hearing the testimony of our esteemed panelists. Senator Burr.
Thank you, Mr. Chairman, and thank you for calling this hearing. I truly thank our witnesses today for their knowledge and for their willingness to be here to share with us their information. In about 2 weeks, our nation will mark the 4th anniversary of the enactment of the Affordable Care Act, better known to most as Obamacare. Today's hearing will inform what direction we will next take health care in America by examining access to care and cost associated with health care systems overseas. As we examine single-payer systems in other countries and what we can learn from their experiences, it seems fitting that we also take stock of where things stand in the American healthcare system today. At the time Obamacare was being debated in this very committee, I warned that it was the wrong direction for our country. Healthcare was broken before Obamacare, but 4 years later, the American people are experiencing firsthand how the new law has made things worse. That's why Americans view the law unfavorably. And that's why they are understandably wary of still more government involvement in health care. The President promised that if you like your plan, you get to keep it under Obamacare. The federal government mandates that Americans buy health care coverage, and not just any coverage, but the coverage the federal government says is good enough. Sadly, millions of Americans have lost their health care plans, health plans they liked and wanted to keep, despite the promises and continued delays of the administration. Obamacare expanded Medicaid an unsustainable health entitlement program in which 40% of physicians on average do not even agree to see Medicaid patients. I believe the experiences of other countries will reinforce what many Medicaid patients already know. Their coverage does not always translate into timely access to care. Today's hearing will also examine cost. While the President promised that Obamacare would bring down premiums by $2,500, premiums have actually gone up by an average of 41% in the individual market due to the law's mandates. So, how does Obamacare attempt to control cost? For starters, it established the Independent Payment Advisory Board, or IPAB, an unelected, unaccountable board of 15 bureaucrats empowered to make cuts to the Medicare program, most likely in the form of cuts to doctors, which will impact, again, seniors' access to care. Today's hearing will be informative as to the direction we take health care in this country. Will we repeal Obamacare and replace it with reforms that lower health care costs, put our nation's entitlement programs on a sustainable path, and empower patients in their health care purchasing and decision-making to find the plans that best meet their individual needs? Or will we continue on the current course of unprecedented government involvement in health care and unsustainable costs? What do we have to learn from a single-payer system overseas, and what have other countries' reforms meant for their patients? What would such a course mean for our nation standing as a global leader in medical innovation, and for American patients seeking access to quality and affordable coverage and care that meets their individual health care needs? I do want to thank Chairman Sanders for holding this hearing, because it will inform many of us on these important questions. I think today's hearing represents an important admission that Obamacare is not working. That such an admission takes place within the very committee that the act was written in is a huge step, and I commend the committee for taking it. I look forward to hearing from our witnesses today and continuing to work with my colleagues to advance patient-centered reforms that will actually lower health care costs and increase access to quality, affordable health care. I thank the chair.
Thank you, Senator Burr. Senator Enzi, did you want to make a statement? Okay. Thank you. We have 7 very knowledgeable panelists, and we look forward to their testimony. We're going to ask you to keep your remarks to 5 minutes, and then we will follow up with some questions. Our first witness is Mei Cheng, a health policy research analyst at the Woodrow Wilson School of Public and International Affairs at Princeton University. Ms. Cheng is an advisor to the China National Health Development Research Center, and we very much appreciate her being with us today. Please speak right into that microphone so everyone can hear you. A little bit loud.
Oh, it's already started counting.
Get close to that mic.
Good morning, Mr. Chairman, Senator Sanders, Ranking Member Burr, and Senator Enzi. My name is Mei Cheng. I'm Health Policy Research Analyst at the Woodrow Wilson School of Public and International Affairs, Princeton University. Thank you for inviting me to testify. I have been asked to give an overview of single-payer systems, and I here distill my written testimony into a few salient points. An overarching point made in my testimony is that single-payer systems are not the same as socialized medicine or socialism, as is so often assumed in this country. In socialized medicine, government owns and operates the healthcare delivery system and finances it. The health system Americans reserve for their military veterans, for example, the VA system, is purely socialized medicine. Single-payer systems typically are just social insurance, like the Social Security system. Under social health insurance, the government merely organizes the financing of health care, but the healthcare delivery system typically is private and can include for-profit entities. Medicare, for example, the social insurance, it is social insurance, but not socialized medicine. The main characteristics of single-payer systems are the following. They are ideal platform for equity in access to health care because everyone has the same insurance coverage and providers are paid the same fees regardless of the socioeconomic status of the patient. Single-payer systems typically are financed on the basis of ability to pay rather than on the basis of health status of the insured. Single-payer systems typically give patients free choice of doctors and hospitals. In single-payer systems, providers of care do not compete on price, but they must compete on quality of care, including patient satisfaction. In a single-payer health insurance system, health insurance is not tied to a job. Instead, it is fully portable from job to job when people lose their job and in a retirement. Does not go away. Therefore, there's no job lock in these systems over health insurance. Because all funds to providers of healthcare in a single-payer system flow from one payer, it is relatively easy to control total health spending in such systems. The international data I cite in my written testimony make that clear. Now, some single-payer systems, like UK and Canada, may put constraints on the physical capacity of their health system, like number of hospitals and MRI scanners, as part of their effort to control total health spending, including waste created by excess capacity. This constraint may lead to rationing by the queue. The alternative to rationing by such administrative measures is rationing by price and ability to pay, something that we see in the U.S. healthcare system. The argument that healthcare is not rationed in the U.S. is not supported by the data. A single-payer system is an ideal platform for modern IT. With common nomenclature, all billing can be done electronically, and it yields enormous savings in administrative costs. And because such an IT system conveniently captures data and information on all healthcare transactions, these systems provide a database that can know spending in real time and is, as in the case of Taiwan, and it is a base for use for quality measurement, monitoring, and improvement. And public satisfaction about single-payer systems is generally high. Denmark, for example, is ranked the number 2 highest in the European Union in consumer satisfaction. In Taiwan, public satisfaction is also very high, with a national health insurance program ranging in the 70s to 80%. In Canada, a 2013 international survey of 11 countries found that 42% of Canadians surveyed said that their healthcare system works well and need only minor changes, compared to just 25% of Americans who said that. 75% of Americans said American healthcare system needs fundamental changes or completely rebuilt. Lastly, survey research has shown that single-payer Medicare is very popular in the U.S. A final point is that every health system has its flaws, which can be highlighted with anecdotes. Therefore, there's now a brisk medical tourism worldwide. For example, Canadians come to the U.S. for health care, but it also is true that Americans go to Canada, Mexico, Thailand, and Taiwan for lower-cost health care. Thank you very much.
Thank you, Ms. Cheng. We're going to go now to Dr. Rodwin. Victor G. Rodwin is a professor of health policy and management at New York University's Wagner School of Public Service. He has worked his entire career on studying healthcare systems abroad with a special focus on France. Professor Rodwin held the Fulbright Tocqueville Distinguished Chair at the University of Paris, Orsay, in 2010. Dr. Rodwin, thanks very much for being with us.
Thank you, Senator Sanders, and distinguished members of the committee. Good morning to all of you watching on C-SPAN. My name is Victor Rodwin. I will speak on the French healthcare system. That system is a model of national health insurance that provides healthcare coverage to all legal residents residing in France. It is not, I repeat, it is not an example of socialized medicine like Cuba. It is also not a national health service as in the United Kingdom. It is also not an instance of a government-run health system like our excellent Veterans Health Administration. French national health insurance, in contrast, is an example of public, social security, and private health care financing combined with a diverse public-private mix in the provision of health care services. The French healthcare system reflects three political values embraced by Americans. Liberalism, in the sense of giving patients free choice of any doctor or any hospital they care to go to, with no networks, no restrictions. Second, pluralism. Everybody has a diverse choice. They can go to fee-for-service solo practitioners, they can go to group practices, they can go to outpatient health centers, they can go to emergency rooms, they can go to public hospitals, private hospitals, outpatient consultations with specialists in public hospitals. The third value is solidarity, in the sense of having those with greater wealth and better health finance services for those who are less well off and in poorer health. Now, in terms of population health, the French outdo us, and I'm embarrassed to say that as an American, hands down. Look at any indicator you like. Life expectancy at birth, they do better than we do. Infant mortality, they do better than we do. Female life expectancy at 65, they outlive us. Female life expectancy at 80, or male life expectancy at 80 years of age, where medical care matters, they outdo us. Disability-adjusted life expectancy, which takes into account measures of disability, they outdo us. Years of life lost, we have more years of life lost. This is not a Republican or Democratic debate. These are the facts. But that's not the way to judge a healthcare system entirely. Surely a healthcare system reflects these indicators, but not just the healthcare system. My colleagues at NYU would still say that we have the best healthcare system in the world in spite of these indicators. They would argue that these indicators reflect other things for which they assume no responsibility. Social services, inequality of income, family policies, which are very strong in France, maternal and child health programs, all of which are factors which explain why they have better population health than we do. So we have to look at other indicators. And one important indicator of health system performance is called avoidable mortality. That is, in a good healthcare system, women should not die in childbirth. People should not die of tuberculosis. People should not die of ischemic heart disease. People should not die of cancers that can be cured. And when we look at that, I'm embarrassed to say that we come out in the United States as 19, and the French come out as number 1. I repeat, number 1. That is a fact that cannot be ignored. It must be addressed. It was written up in Health Affairs, a reputable journal. It was confirmed with different measures by the OECD, and it has not received, in my judgment, sufficient discussion. Another indicator of how well a system is doing, and a theme of this subcommittee that I know is dear to Chairman Sanders, is access to primary care. You can talk about primary care till you're blue in the face, but let's look at the consequences of whether you receive primary care or not in different healthcare systems. We have a very established measure of primary care access. It's very direct. If people end up in the hospital for conditions for which you should not have exacerbations if you have access to primary care, that's called avoidable hospitalization. And on that criterion, avoidable hospitalization, the rates of avoidable hospitalization are twice as high in the United States as they are in France. That's an unfortunate statistic from the point of view of an American, but that's the way it is. Lessons that we can draw. I believe that health systems cannot be transplanted from one country to another, but we can talk about some issues, and I'll just tick them off. I'll go over 30 seconds if you'll allow me, Mr. Chairman. In France, there's no choice of insurance plan. Everybody's in the same plan for the standardized benefits, but there's a complete choice of hospital or doctor. In France, all insurers, and there are more than one, pay the same price according to nationally set rates. You don't have a lower price for Medicaid, a higher price for Medicare, and even higher price for commercials. In France, there are no physician gatekeepers. Everybody can go where they like. No one's telling them what network they can or cannot go in. They don't have to call their insurance company to get authorization. In France, there's extensive co-insurance, small, but there's a voluntary health.
We're going to have to learn more about France in a few minutes. Senator Murphy, did you want to make a brief opening remark? No, okay. Let's go to Dr. Ye. If I'm pronouncing your name, forgive me if I'm not. Dr. Ye is a professor at the School of Public Health, Tsuchi University in Taiwan. And we very much appreciate your being with us today. Just speak closely into that microphone and tell us a little bit about what goes on in Taiwan.
Chairman Sanders, Senator Burr, and distinguished members of the committee, thank you for inviting me to testify here. My name is Jin Chuan Ye. I'm the professor at the Tsuchi University, but I was the founding CEO of our National Health Insurance Administration in 1995 to 1998. That is 19 years ago. And I was the Minister of Health in Taiwan. And Taiwan established the Universal National Health Insurance in 1995. Currently, 99.6% of our population enroll in this program. The other 0.4% is they have citizenship but stay abroad. They are not covered. Taiwan's NHI program is a single-payer system and has a large single risk pool. Before that, we have 12 different social programs, strong and weak program, and we merge into one single pool. That enabled us to have cross-subsidization among the rich and poor, the well and the sick. Study shows that the premium contribution compared to the health resources utilized are favorable to the low and middle income. Having a single-payer system is the main reason for our efficient services and also how at the low prices of our health care we can achieve. We have a private not-for-profit delivery system, and very highly competitive providers enable us to have efficient service. We contract 100% of the hospital in Taiwan and 93.5% of the private practitioner, and enable us the insurer. If they have the car, they can go anywhere, any hospital, any private practitioner for seek the advice. And that enables us a very easy and equal access to the system. And single insurance administration have the benefit of very low administrative costs, which is only 1.15% of the total NHI spending. And people enjoy complete free choice of provider, and provider in Taiwan must be mindful of their patients' demand to stay competitive. Our satisfaction rate is, after 2 years of the implementation, it's always between 70 to 80%. We have a national fee schedule, uniform fee schedule. So the cost of the hospital and the provider can only compete on quality instead of price competition. And patient carry their insurance card can go to any provider if they are not satisfied with their quality of services. Basically, there are no waiting lists at all, except for a few well-known medical institutes or well-known doctors. And rationing is solved by provider competition and efficiency of our services. In 2012, our life expectancy, our infant mortality, our maternal mortality, and some clinical indicator, we are much better than U.S. Although we spend only 1/6 of the U.S. dollar, if PPP adjusted, it is 1/4 of the U.S. dollar we spend. But we are doing better than U.S. And last thing I wish to mention is our IT system, health information system. Everyone have this card, and with 6 last visit record in this card. But actually, all our providers submit their data electronically. So we are on the way to develop a closed system EMR. So we expect to accomplish a lifelong e-record for everyone in the next few years. I think my time is up. Thank you
very much, Ms. Pipes. Turns out we have another Canadian with us as well. Our fourth witness is Dr. Danielle Martin, a primary care family physician actively involved in practice at Women's College Hospital in Toronto, Canada, where she also holds an administrative leadership position as Vice President of Medical Affairs and Health Systems Solutions. Dr. Martin, thank you very much for being with us.
Chairman Sanders, Ranking Member Burr, distinguished committee members, thank you for inviting me to address you today. My name is Danielle Martin. As a practicing physician and Vice President Medical Affairs and Health System Solutions at Women's College Hospital, I have daily first-hand experience with the Canadian single-payer system. In addition to my clinical training, I also hold a master's in public policy from the University of Toronto, where I am currently an assistant professor. I do not presume to claim today that the Canadian system is perfect or that we do not face significant challenges. The evidence is clear. The evidence is clear that those challenges do not stem from the single-payer nature of our system. Quite the contrary. Working within a public insurance structure helps us to better tackle many of the challenges shared by all developed nations in healthcare, including rising costs, variations in quality, and inequities of access. I would like to highlight for you today 3 major benefits of the Canadian single-payer model. The first is equity. Poll after poll has demonstrated a strong consensus among Canadians that access to healthcare should be based on need, not ability to pay. While, of course, we continue to struggle with inequity on other fronts, it is worth emphasizing that at substantially lower cost than in the U.S., all Canadians have insurance that covers doctor and hospital care. We do not have uninsured residents. We do not have different qualities of insurance depending on a person's employment. We do not have an industry working to try to carve out different niches of the risk pool. This is a very important accomplishment, and as we watch the debate unfold in the U.S. as to how to address the challenges you face, we are reminded daily of its significance. One of the big challenges in a multi-payer system is the question of how to achieve policy reform with so many players in the game. In a single-payer framework, if government and providers identify a significant challenge in the healthcare system, they can work together at the bargaining table to align financial incentives to advance their shared policy objectives. An example upon which I elaborate in my written submission is the way in which Ontario's government and physicians have worked together to increase the number of medical students choosing primary care as a career and choosing to work in rural underserviced communities. Finally, one cannot speak about single payer without addressing the issue of administrative costs. It has been estimated that if U.S. administrative costs were curtailed to the level of those in my home province of Ontario, the total estimated savings here would be $27.6 billion per year. Indeed, overall, as you've heard, we spend a much lower proportion of our GDP on healthcare in Canada, 11.2% as compared to your 17.9%. And importantly, this is not at the expense of quality. Canadians enjoy the same or better health outcomes as Americans, both at the level of life expectancy and infant mortality, as you've heard, and when we look at outcomes for a range of acute and chronic illnesses. In fact, a recent scientific systematic review found that Canada achieved health outcomes that are at least equal to those in the United States at 2/3 of the cost across a very wide range of diagnoses. The issue of wait times is very widely covered, I note, in American media. When it comes to urgent and emergent care, Canadians are not waiting, substantially longer than our peers in other countries, including the United States. Unfortunately, it is true that that has not been the case for elective medical care, such as non-urgent diagnostic imaging and elective surgeries. A great deal of work is underway to address this challenge, and indeed waits have been decreasing over the last decade for a variety of elective medical procedures. It is important to note that moving away from a single-payer model would likely exacerbate our wait time challenge rather than alleviating it by drawing critical health human resources out of the public system. This is borne out by international evidence from other jurisdictions such as Australia. The Canadian system is proof that public health care insurance need not be provided federally in order to achieve the benefits of the single-payer model. In Canada, each province provides public health care insurance to its residents with minimum standards set at the federal level. Furthermore, moving to single-payer insurance, as you've heard, does not necessarily mean moving to the direct provision of health care services by government or socialized medicine. Although our provincial health insurance plans in Canada are financed publicly, almost all health care services are delivered by private entities. This includes our hospitals, which are mostly independent not-for-profit entities, and also our providers, most notably physicians, who are not employees of the state, but rather independent contractors who happen to bill a public insurance plan for their services. I want to reiterate my thanks to the committee for giving me the opportunity to present to you today. I look forward to your questions and engaging in dialogue.
Dr. Martin, thank you very much. Senator Byrd, do you want to introduce your other guest? Last but not least, witness is Jacob Kjellberg. Dr. Kjellberg is a professor and program director for health at CORA, the Danish Institute for Local and Regional Government Research. Mr. Kjellberg, thank you very much for being with us.
Thank you, Chairman Sanders and Ranking Member Burr, members of the committee. I would like to thank you for the opportunity to participate in this hearing. I've been asked to give an overview of the Danish healthcare system. The Danish healthcare system is an example of a health system providing comprehensive and universal coverage for all patients. No patients may be denied services on the basis of income, employment status, age, or health status. Most patients in Denmark are listed with a GP of their choice. All visits to the GP are free, and the use of all specialized health services is free with a referral from the GP. Patient can also choose Group 2 health insurance and access specialist treatment directly. But a Group 2 patient will face a co-payment for visits to GP and specialists practicing outside the hospitals. Only about 1% of the population have chosen Group 2 health insurance, and people are generally quite satisfied with the GP system. If referred to a hospital treatment, patient may choose among all public hospitals offering the relevant treatment. All hospital treatment is free, including all hospital drugs. Patient may all choose among private hospitals in Denmark or hospitals abroad if the waiting time exceeds 1 or 2 months, depending on the severity of the condition. Many patients prefer to stay with the local hospital, therefore median waits can't be longer than the waiting time guarantee, but it's a choice. If cancer is suspected, we now offer a 2-week waiting time guarantee for examination and treatment. It had previously been a problem, as you mentioned. To finance a healthcare system, the state collects the necessary revenue through general taxation. The state funds the regions, and they on basis of objective criteria. This ensures equal opportunities for the regions across the country. The simplicity of the financing structure also keeps the administrative cost low. Only 4.3% of the total health spending is used for administration. The public sector finances about 85% of the total health expenditure. The 15% private expenditure mainly covers out-of-pocket payments for primary sector pharmaceuticals, dentistry, and optical services like glasses and contact lenses. About half of the population has supplementary health insurance to cover the out-of-pocket payments. There are also other supplementary health insurances where you can access health care quicker than the 1 month or 2 month waiting time guarantee or free access to physiotherapist. But the supplementary health insurances covers less than 1% of the total healthcare budget, but it's a choice. The health status in Denmark can generally be characterized by it being good. Surveys showed that 85% of the population perceive their own health status as excellent or very good. The life expectancy is on average 80.1 years. Historic high smoking rates is typically blamed for the relatively low life expectancy in Denmark compared to the other Nordic countries, not the system or the health system. The European consumer powerhouse ranks all the European healthcare systems, and here the Danish healthcare system ranks second in Europe. Denmark scores especially high on patient rights, range and reach of services provided, and information. Denmark scores relatively low in prevention and health outcome disciplines. Health expenditure in Denmark is slightly above OECD average when you look at the statistics. However, Denmark has a practice of reporting certain expenses for social care as health expenditures. If these costs were reported in line with the practice used in most other countries, the Danish health expenditure is significantly below OECD average. To sum up, the Danish healthcare system is an example of a transparent healthcare system that provides comprehensive and universal coverage and high level of patient satisfaction. The simplicity of the system keeps low cost and makes it easy for the patient to access health care. I would be happy to answer any questions you might have. Thank you for the attention.
Thank you very much, Mr. Kjellberg. Now we'll begin with questions and comments, and let me begin. Let me begin by asking all of our distinguished panelists a very simple question. In the United States today, we are the only nation in the industrialized world that does not guarantee people health care as a right. And we still have, well, the numbers have gone down since the Affordable Care Act, but we still have many, many millions of people who have no health insurance at all. Others have high co-payments or deductibles. So let me ask all of the panelists a very simple question. Should health care be a right of all people, regardless of income? Yes, no, maybe. Ms. Cheng, should health care be a right of all people?
I think it should. I think it should because it is a sign and expression of a civil society.
Okay, I'm going to ask the brief answers. Dr. Ye?
Yeah. Access to health care regardless of their job, their income, is an inalienable right in our Constitution.
Okay. Ms. Pipes?
No. We're entitled to life, liberty, and the pursuit of happiness. How do you determine which right is worth more? Do we have a right to housing, a right to food, a right to health care? How do you measure which is the appropriate level? So, no.
Okay, thank you. Dr. Martin?
Yes, access to health care is a human right, and I know that the vast majority of Canadians in poll after poll feel the same way.
Mr. Kjellberg?
Yes, I believe that access to health care should be a right.
Dr. Hogberg?
Yes, I think it should be a right in the classical liberal notion of rights, that government should not interfere, Congress should make no law, and so forth. So yes, everyone should have the right to health care in that sense.
Dr. Rodin?
We have a right for health care in the United States for emergency care. I believe that should be extended to primary care as well.
Okay. Let me stay on that point, maybe get to Dr. Hoberg. You indicated that you thought health care should be a right, but government should not be involved in that process. Does that suggest that you would do away with the government-run Medicare program?
It's a moot point.
No, it's not.
It's a very moot point because seniors vote at very, very high rates, and we're not getting rid of Medicare. It's an academic
But I'm
question.
asking you as an academic. You're not seniors do want it. You're right. It's a popular program. Mm-hmm. But if you say government should not be involved in health care, and Medicare is a government health care program, mm-hmm. in your judgment, in the best of all your possible worlds, should we vote to get rid of Medicare? Some people think we should. What do you think?
I think it's a moot point. It's here to stay.
Well, I think you didn't answer my question. Ms. Pipes, I would like to ask you that question.
I believe that we are not going to get rid of Medicare. Medicare is a program for our seniors. I think we do have severe problems. The Medicare trustees have said that Medicare will be bankrupt by 2024, just at a cost of over $1 trillion.
I just wanted to ask you a simple question.
It should be
Medicare is a government-run program.
Right.
As Dr. Hoberg indicated, I think it's a popular program. We could disagree. We have disagreements. My question is, should, in your judgment, we abolish this government-run Medicare program?
Not entirely. Medicare should be there for those people who truly need it. The problem is...
Truly need it, but not as it is right now.
Because a lot of people who are wealthy can afford care, and they're
not a lot of
putting
people
a lot
are
of cost
wealthy.
pressure
All right.
on the system. Paul
Okay.
Ryan,
Let me ask,
Congressman Ryan, I think has some very good ideas
Right,
on
and he would
premium support,
transform
changing the
Medicare
age.
into a voucher program. Dr. Rodman, let me ask you a question. Despite the fact that our health care outcomes are not particularly good in terms of infant mortality, in terms of life expectancy, the United States ends up spending almost twice as much money per person on health care as any other nation. Why is that? And I'm going to give you, and we'll give Senator Burr additional time as well. Dr. Rodman, why is that? Put your mic on.
We spend more, Senator Sanders, for several reasons. First, our prices are higher than all other wealthy OECD nations.
All right, if a woman has a birth in this country compared to France, how much more does it cost? Or give me some examples.
It can cost different prices here depending on who insures you. It can range from the $5,000 to $27,000. The figures are in the excellent paper by Mei Chen from OECD for all to see. So price is one very, very important phenomenon. Prices of drugs, prices of...
How do drug prices compare in the United States compared to other countries?
In the aggregate, they are much higher.
Why is that?
Why is that?
Yeah.
Because we have no price control. Because
So if I need a cancer drug in the United States, why is it much more expensive here than it is in Canada or in France?
in Canada and in France, you have regulated prices for these drugs, and people have access to them. In France,
That interferes with the free market system. Is that a good idea?
of course, it's a good idea. The free market system doesn't exist anywhere in healthcare. I challenge anyone to give me one example of a free market system that is operational and works. It's a fine idea in theory, but I challenge anyone to give me one concrete example. All the evidence suggests that it does not work.
Okay. Senator Burr.
Dr. Martin, in your testimony, you note that Canadian doctors exiting the public system for the private sector has had the effect of increasing waiting lists for patients seeking public health care. Why are doctors exiting the public system in Canada?
Thank you for your question, Senator. If I didn't express myself in a way that to make myself understood, I apologize. There are no doctors exiting the public system in Canada, and in fact, we see a net influx of physicians from the United States into the Canadian system over the last number of years. What I did say was that the solution to the wait time challenge that we have in Canada, which we do have a difficult time with waits for elective medical procedures, does not lie in moving away from our single payer system towards a multi-payer system. And that's borne out by the experience of Australia. So Australia used to have a single tier system, and in the 1990s moved to a multiple payer system where private insurance was permitted. And a very well-known study by Duckett et al. Was tracked what took place in terms of wait times in Australia as the multi-payer system was put in place. And what they found was in those areas of Australia where private insurance was being taken up and utilized, waits in the public system became longer.
What do you say to an elected official who goes to Florida and not the Canadian system to have a heart valve replaced?
It's actually interesting because, in fact, the people who are the pioneers of that particular surgery, which Premier Williams had, and had the best health outcomes in the world for that surgery, are in Toronto at the Peter Monk Cardiac Centre, just down the street from where I work. So what I say is that sometimes people have a perception. And I believe that actually this is fueled in part by media discourse, that going to where you pay more for something, that necessarily makes it better, but it's not actually borne out by the evidence on outcomes from that cardiac
one would believe
surgery
the
or any
American
other.
people prefer their system because they know consciously they pay more. No, I think it's because they judge quality and they judge innovation. Ms. Pipes, in your testimony, you noted that more than 42,000 Canadians come to the United States each year for health care. Why is that?
Because they find that they're on a waiting list in Canada for too long a period and they feel that their health is at stake. So a lot of people in Canada come to the U.S. for MRIs, CT scans. There are many examples in the media of people like Brian McCreath who came to the U.S. because he was told by his primary care doctor that he might have a brain tumor, but the wait for an MRI was very long. He spent the $1,000, came to the U.S., paid out of pocket. You will see advertisements in Canadian newspapers for MRIs, for neurosurgery.
It's a pretty fertile ground to market in.
Right.
Dr. Martin, in your testimony, you state that the focus should be on reducing waiting times in a way that's equitable for all. What length of time do you consider to be equitable when waiting for care?
Well, in fact, the Wait Time Alliance in Canada, sir, has established benchmarks across a variety of different diagnoses for what's a reasonable period to wait. And what we've found is that actually working within the single payer system, we can reorganize things. You know, I waited more than 30 minutes at the security line to get into this building today. And when I arrived in the lobby, I noticed across the hall that there was a second entry point with no lineup whatsoever. Sometimes it's not actually about the amount of resources that you have, but rather about how you organize people in order to use your queues most effectively. And that's what we're working to do, because we believe that when you try to address wait times, you should do it in a way that benefits everyone, not just people who can afford to pay.
On average, how many Canadian patients on a waiting list die each year? Do you know?
I don't, sir, but I know that there are 45,000 in America who die waiting because they don't have insurance at all.
Well, let me go back to Dr. Rodwin's statement. The American system has access to health care for everybody. It's called the emergency room. Now, we don't admit that clearly because we're lobbying for a particular angle. But every American can access health care. They can access primary care. And Dr. Rodwin, I would agree with you that we ought to make sure that there's a medical home for practically everybody we can place. We don't do it in Medicaid. We should. States should adopt it because primary care is an absolute necessity to wellness. But, Mr. Kjellberg, how many Danish citizens have supplemental health insurance policies, and why has that number been increasing in recent years?
About half the population got co-payment for co-payment insurance, and that have increased dramatically over the last year because your family were included, so children were included, and that brought up the numbers quite significantly. But the number for policyholders haven't really changed much.
But half the population has supplemental insurance.
Co-payment insurance. And then many people in the labor market also, as part of a benefit package, are offered health insurance so you can have faster access to elective care.
So they can actually buy their way to faster access.
Oh, you can buy that. There are private hospitals. You can buy any hospital services in Denmark.
So they have options. They have choices.
They have choice, yeah.
Dr. Rodwin, in your testimony, you note that Parliament sets health care expenditure targets each year. If a hospital or a physician exceeds their target expenditure by billing for higher than projected volume of services, prices are negotiated downward for the following year. Beyond volume or utilization of services, are there quality metrics that the French use to determine reimbursement for physicians or other providers in order to incentivize quality care for patients? For example, measuring health outcomes to ensure patients are receiving quality care.
This is a science that's not well developed neither in our country nor in France, but they are working on this very question, which is very timely, right now. That is, the negotiations focus certainly on volume, but now there's a program called IFAC, which will remunerate physicians. Well, that's actually already in place if they follow certain standards of preventive care.
But they're penalized if they bill at a higher rate one year. They're penalized in the next year by a reduction in reimbursement.
Every year, sir, there's a negotiation to set these rates, and if the volume goes up, then the following year the prices. That's the practice. It's the volume health performance standard.
Thank you, Doctor.
Yes, it's a
Thank you, Mr. Chairman.
budget target.
Senator Nancy.
Does Prime Minister Harper does he change the rules and delay implementation of the system every week like we see going on with the Affordable Health Care Act?
I'm not sure that you want me to answer that question, sir. I don't completely understand what you're saying. But
I'm saying that the Prime Minister of Canada, I don't think, changes the National Health Care Act that we have in place, which I think is basically a first step toward single payer, and I think that was the intent of it. The President of the United States has changed the health care. About every Friday we have what we call a regulation dump, okay? A consortium of unions indicated that they would like a big change in the Affordable Health Care Act. He's going to have a carve-out for them. On the other side of the fence, 27 members of the Finance Committee, some on this committee, wrote to Marilyn Tavender, the head of the Centers of Medicare and Medicaid Services, to say, whoa, don't change the Medicare D program that we have in this country, a very popular program under budget, used by a great number of our senior citizens. And if we hadn't written the letter and if there hadn't been a real backlash from the people to save Medicare Part D, it wouldn't have happened. So we're just sort of writing this thing as we go along, except the President doesn't come to us and ask us to help him do that with each individual change. I'm just wondering, with the problems you have up in Canada, who makes the change, if in fact there needs to be a change?
Well, I suppose there's the answer to your question comes in two parts. The first is in acknowledgement, I think, of what Senator Enzi was saying earlier on, which is that like the United States, Canada is a huge country, and our health insurance is actually not provided at the national or federal level. It's provided at the provincial level or the equivalent of your states. And so the notion that something can begin in one subnational jurisdiction and then spread is in fact exactly how we came to have 13 separate single-payer systems in the 13 provinces and territories of Canada. And so the first part of the answer to your question is no, we don't see that kind of those kinds of changes being made to healthcare legislation at the national level. But the second part of the answer to your question is that it is widely known in Canada that the public commitment to our single-payer Medicare system is so strong that for a prime minister of any political stripe to try to alter that and undermine it in any way would be political suicide.
I got your message.
How in other countries where there may be less easy access to health services, not as much health care as we have in the United States, we have tons of it, as to whether that actually has a true relation all the time to the outcomes that we get. Dr. Martin, happy to have you start.
Thank you. It's a really thoughtful question. And I guess I might reframe it slightly by saying that what you refer to as convenience, I would refer to as patient experience. And so when we talk about quality in healthcare, the so-called triple aim, coined by Don Berwick of the IHI here, the notion of quality having three dimensions. One is population health outcomes, on which single-payer countries like Canada fare, in fact, quite well. Another aspect of the triple aim is cost per capita, and the third is patient experience. And of course, patient experience is important. And so, you know, I said that I wasn't here to be an apologist for every single thing about the Canadian healthcare system. We're working very hard on reducing wait times for elective surgeries because we believe that patient experience matters. But you're right that our outcomes are very good. And I think it's critically important for the committee to understand that single payer does not equal wait times. We heard our colleagues from Taiwan tell us quite clearly that they have a single payer system with virtually no wait times, with 99.6% coverage of the entire population. And so, of course, we should consider all aspects of the triple aim when we talk about quality, but we should not, we should avoid oversimplifying the message and equating a single payer model with wait times. That simply is not the case.
Right now. So I think this has been a very thoughtful and vigorous discussion, and I appreciate all of you very much for being here. Thank you. This hearing is adjourned.